Hello, it is my pleasure to introduce the Society for Pediatric Anesthesia sponsored session, Patient and Family Centered Care to Achieve Equitable Outcomes in Pediatric Anesthesia. I received funding from the National Institutes of Health, and today I will talk to you about how to address disparities in pediatric perioperative care through patient and family centered care models. The objective for this first panel is to explain what is patient and family-centered care, to describe how health determinants affect perioperative care using population health and health services conceptual frameworks, and I will illustrate concepts discussing aspects of perioperative care for language diverse family through my talk. This talk is also an introduction for the next two presenters, who will talk to us about patient-centered care for racial and ethnic minority children and transgender children. So patient and family-centered care is provision of care that is respectful of, but mostly responsive to individual patient preferences, needs, and values to guide clinical decisions. And while this is not a new concept, implementation has been challenging, especially because systems are really focused on providing health services that are disease-oriented, technology-driven, and centered around the healthcare system itself. And for some, this may not feel that is the case, but I hope that at the end of this talk, you would be able to appreciate how our systems are really not catering to our patients. The change that we propose is to use patient-centered approaches that recognize that before people become patients, there are individuals within a family, a cultural group, and a society. So we want to move from equality in healthcare to equity in healthcare. And the fundamental change is to understand that one size does not fit all, and that we need to acknowledge the differences in our patients. So our current systems treat all patients the same way, meaning equally. What we want to do is to actually provide systems that treat patients according to their values, their cultural backgrounds, their needs and preferences. What are the principles of patient-centered care? The first one is that care and communication are based on shared decision models. To do so, patients and family needs to be informed in order to be really considered partners during decision-making processes. Second, institutions have to take responsibility to be responsive to the needs of the patients in order to provide equitable care. And we have to increase our responsibility beyond only providing safe care to really assess and address the needs of our patients in order to provide the same level of care to everyone. I'm going to start an example around the importance of looking at language diversity in perioperative care. So each year, 3.4 million children in the United States undergo a surgical procedure. Of those, 5% belong to families with limited English proficiency. Limited English proficiency is defined by the US Census as speaking English less than well or very well. And why is this important? Limited English proficiency is associated with 50% lower likelihood of having surgery, as well as delayed surgical diagnosis and higher severity at the time of surgery. Specifically, and populations in which they have appendectomies, it has been seen in studies that children of limited English proficient families come to a hospital later and are more likely to have a perforated appy. LEP is also associated with delayed post-surgical analgesia administration after orthopedic procedures in children and higher rates of adverse events during hospitalization, both for surgical and medical pediatric populations. So if you look at this list, access, time of surgery, analgesia, and adverse events, all of these are quality measures. Health disparity is a health difference that adversely affects a disadvantaged population. And we have to take into consideration that disparities in healthcare are contextual and are multifactorial. And that's why having a disparity framework, it's really useful because frameworks provide context, guide and ground implementation of the strategies, facilitate interpretation, and help guide future work. There are basically two types of frameworks, the population health frameworks and the health services frameworks. The most notable of the population health frameworks is the WHO. And these frameworks basically focus on causes of disparities within communities or societies. The health services frameworks are those that focus on work within the context of a healthcare system. Today, I'm going to start with the NIH framework because it's useful for us to understand a couple of principles in terms of healthcare disparities. The first one is that the NIH specifically calls and describes what are populations at risk. So if you see here, and these are populations at risk for the United States. So if you look at this race and ethnic minority groups, individuals from low socioeconomic status, rural areas, and sexual and gender minority patients are at higher vulnerability. This framework also shows very well how disparities are multidimensional, both in the domains of influence as well as the levels of influence. It also shows the cumulative effect of risk factors in the life of an individual and the intersectionality, meaning there are several risk factors that can have compounding effects for a single individual, and you can see that in the green circle. Now, moving to the healthcare system, specifically preparative care, here is a health services framework. First of all, you can note that it has the same aspects that the NIH framework showed, but basically is centering this healthcare system around the clinical encounter. And when we look at the clinical encounter, we have to account for patient factors and provider factors. So going back to our example, in the United States, there are approximately 2.2 million children that have limited English proficiency. And these kids are children between the ages of 5 to 17, which are actually school-age children. What is important for these children is that they have additional risk factors. They're more likely to live in families in poverty, and they're more likely to have parents with less than high school education. These families and these parents have lower levels of literacy and health literacy in general. But what about us as clinical providers? We can also bring things to this equation. We bring our knowledge, of course, but we also bring our attitudes and biases in a place in which we are working with a lot of competing demands. So when we come to the clinical encounter as anesthesiologists, we usually meet the patient the day of surgery and have really a very limited knowledge of our patient. And our knowledge is basically focused on factors that we feel or perceive that are directly related to the anesthetic. We'll look at the airway, we'll look at cardiovascular and respiratory comorbidities, and MPO status or medications. And this is understandable because we work in a system that has a lot of time constraints and is really pushing for efficiency. However, this is not an ideal situation because studies show that we introduce biases, implicit biases, in situations in which there is time constraints, less knowledge of the context, and situations of high stress, which is exactly the place in which we work. So what would be the ideal clinical encounter for this patient? Well, if there is a way to do screening for social determinants of health prior to the procedure and have this information readily available for the anesthesiologist, that would be the ideal situation. And this is actually possible. There are already systems that are introducing this concept of asking for social determinants of health in the preparative care. So going with our patient, in addition to understanding what is the preferred language of care, we should be asking what is their level of education and literacy. And why is this important? Most of our discharge orders are written. And if a patient cannot read orders, they just have to remember what we told them. So if we discharge a patient with a peripheral nerve catheter in which they have to check for a couple of things in their house, it would be really useful if we support the patient to really be able to follow the orders that we're giving. We also know from the literature that there are more frequency in medication dosing errors in patients with lower levels of literacy. So if we increase our knowledge of the patient, we really be able to support them in shared decision-making processes, and we will improve communication. So how to move forward? We have to start thinking beyond only detecting disparities, which is the phase 1 of the disparities work agenda. This phase is important, but we have to move forward to understanding why these disparities are happening in order to really reduce, implement interventions and reduce these disparities. Following the example of language diverse families, what we could do is to do a needs assessment of our surgical population, and aid ourselves using other tools. LEP.gov has maps that give you the proportion of LEP families or individuals by county. And it also gives the most frequently spoken languages. So this is good because it will help you to provide support services that are adequate to your surgical population. What are the services? Well, the ideal service would be to provide language concordant care. This is hard, but I would say that it's not impossible, especially for languages that have higher percentage of individuals. So for example, there are already examples of clinics, surgical pediatric clinics in Spanish, and these clinics have shown that they are very time efficient and that they also facilitate, obviously, communication between the patient and the provider with higher understanding and knowledge for patients, and really higher levels of satisfaction both for patients and providers, clinical providers. If this is not possible, interpretation is really a very good way to provide support to the patients. There are several modalities of interpretation, and all of them have shown to be beneficial. We know from studies that using interpretation in a consistent way during hospitalization improves analgesic administration and improves adherence to treatment. Translation of forms are also important, and for those patients that cannot use written information, either because they have low levels of literacy or because the language that they speak does not have a written form, then video and audio discharge instructions have also that have already proven to be effective in the emergency department. So in the perioperative period in general, how can we promote patient-centered care? We already talked about the strategies at the individual, patient, and family levels. But for us as clinicians, we should really strive for increasing our knowledge and competency around our patients. And that is what this panel is about. With that, we will enhance our commitment to quality, safety, and equitable care. At the systems level, we should create and support inclusive systems that normalize patient experiences rather than making exceptions for patients. So asking about language preferences in language of care is one example, as well as asking everyone for their preference for the pronouns to be used in clinical care. This would definitely improve patient care and would improve outcomes for everyone. Thank you.
Hello everyone, my name is Buki Nafiu. I'm a pediatric anesthesiologist at the Nationwide Children's Hospital in Columbus, Ohio. I'm going to be speaking to you over the next 15-20 minutes or so on the important, complex topic of racial disparity in pediatric surgical health. I have no conflict of interest to declare, although I remain hopeful. But I will say that you should brace yourself for some of the things that I'm going to be discussing in the next 15 minutes or so, because it's impossible to discuss the topic of racial disparity without it generating some visceral reaction and without it being uncomfortable. As a matter of fact, we always say that if you're discussing racial disparity and it doesn't strike a painful chord, then you're not doing a good job. So brace yourselves. So this talk is going to be divided into 3 parts, basically. The first part will look at definitions and data, and then I'll spend quite a bit of time looking into history, because we know that those who fail to learn from history are doomed to repeat the mistakes of the past. And then we will try to race towards some solutions. So first of all, some definitions. This is how the National Institute of Health defines health disparity, talking about differences in the incidence and prevalence of various health outcomes or various health metrics that exist within or between populations in the United States. And the World Health Organization defines health as a state of complete physical, mental, and social well-being of the human organism. In other words, not just the absence of disease in your flesh and bones, but the complete set of well-being. The other terminology that we often come across is the difference between equality and equity. I know that my colleague, Dr. Jimenez, has mentioned this, so I'll just briefly underscore the importance, because I know I'm speaking to a group of anesthesiologists. This is how the panel on the right indicates or signifies the difference between equity and equality. We don't say we use just one laryngoscope blade for all patients. Instead, we say I will use whatever laryngoscope blade is most appropriate for the particular patient. So that's the difference between equity and equality. And then, of course, there's also the terminology, what's the difference between a racist and racism. I will say that people tend to get these two terminologies confused, or they tend to mix them up. Racist is often described as somebody who is bigoted, who is a bad person. So most people don't like to hear the word racist. But we live in a society where racism or systemic racism is endemic and it's in the air. So I will challenge us that racism is our enemy. That's where we should focus all our attention on. This is how structural racism is defined by Bailey et al. In 2017. I really like this definition, in that they talked about structural racism as the totality of ways in which societies foster race and ethnic discrimination through a number of mutually reinforcing systems, essentially underscoring the fact that systemic racism or structural racism is a system of power differentials between populations. And that's going to become relevant as we go along. So really, so many factors affect the health of the children that we take care of. And as you can see from this slide here, I've purposely used small or lowercase fonts to designate the role of biology, because I believe strongly that even though that we tend to focus a lot of attention on biology, the differences between the races and ethnic groups in terms of biological and genetic differences or metabolomic differences and all the other omics differences. I would challenge us that what is important is that we should focus on the humanomics differences. Then, of course, for us to understand that as healthcare providers, medicine is but a small microcosm of a larger society. As a matter of fact, before any of us ever learned to spell the word medicine, whether whether we're doctors or nurses or pharmacists, or before we ever began to work in the healthcare industry, we were first socialized in our various environments. That's the society we came out of, and invariably that is the society we all go back to at the end of our workday. So medicine is a small part of the society. And the role of social status and all the other social factors that have an impact on a child's health cannot be overstated. And then, of course, there's a big question of race, which is an immutable factor. And I would venture to say that systemic racism is the linchpin. It's in the air, whether we like it or not. Systemic racism is like gravity. When you live in a racialized society, so whether you believe in that system or not, it impacts the lives of every one of us. So let's examine some data. And I promise you this is not going to be a data-heavy talk. So a couple of years ago now, this was published in 2017, we examined the question of whether there are differences in the post-surgical outcomes of children, black and white children, based on their ASA, the preoperative ASA classification at the time of surgery, to see whether there will be differences in their outcome. Because as we know, the conventional wisdom is that the sicker the patient at the time of surgery, the worse or the higher the likelihood of complications occurring. And traditional thinking is that African American patients or African American children tend to present with higher preoperative comorbidity burden. So this was a retrospective study. We looked at the National Surgical Quality Improvement database from 2012 to 2017. Final sample was just over 172,000 children that were classified as ASA 1 and 2. And we did all the standard statistical analysis for the key findings from that study. Was as expected, because these were relatively healthy children, the complication rates were low. The overall complication rate was 5.7%, and mortality rate was also low, 0.02%. But what we did not expect was that relatively healthy African American children would have almost 3.5 times greater odds of dying following surgery compared to their white peers. They also had about 18% greater odds of developing postoperative complications. Needless to say that this particular paper generated a lot of interest in the press, and so we subsequently asked another question. What is the economic implications of this healthcare disparity or disparity in outcomes? In other words, are we actually already paying for some of these disparities? So we looked at data using the national inpatient sample over a 20-year period, essentially looking at the median hospital costs between African American and white children coming in for appendectomy. And what we showed is that, as you can see from this graph here, On the y-axis will be the median hospital cost, and on the x-axis is the year of surgery. And at no time during the study period, did those lines cross, suggesting that healthcare disparity is ever prevalent and it's costing us. And since that time, my group and I, we've essentially stuck to the message. We've demonstrated health disparity across various surgical specialties, and other investigators have shown essentially the same thing. It doesn't matter which specialty you look at, whether it's neonatal surgery, pediatric surgery, child life, hospital security. Black families are more likely to have hospital security called on them compared to their white peers. So let's delve into history a little bit. What can history teach us? This is the very first time that the nation attempted to sort of categorize people within her borders was in 1790. And there were only three categories of people living within the American borders at that time. You have Europeans, African, or Native American. That has since morphed into various categories. But I want to point out this quote that was ascribed to Jefferson Davis on the floor of the Mississippi Senate in 1860. He said, "Black inferiority has been stamped from the beginning directly onto the bodily frames of Africans at the moment of creation." By the way, Jefferson Davis eventually went on to become an American president. The panel, the picture on the right depicts a young man that was brought in from the Congo. His name was Otabenga, and he was being paraded in the Bronx Zoo, living in monkey cages and being exhibited in the Bronx Zoo as the African living with monkey. In the last couple of years or so, the Bronx Zoo has since apologized for the story of Otabenga, but history does matter. Some of these pictures that I'm showing are fairly recent, so that these are not events that happened 100 or 200 years ago. The picture on the left there needs no closed caption. The one in the middle, that gentleman wearing a suit as if he's just coming back from Sunday school or is going to teach high school students, was pouring hydrochloric acid into the swimming pool so that black families cannot swim. And this was in 1968. The one there on the lower panel is showing police officers arresting black people from swimming. We live in a racialized society, so we need to acknowledge that. As healthcare providers, swearing a Hippocratic oath does not immunize us against systemic racism or against racism. We know about some of the medical apartheid or medically sanctioned experiments that have gone on. The most popular one, or the most often cited one, is the Tuskegee experiment. But there are so many examples in history, including those of Dr. Marion Sims, who was credited with performing surgical procedures on slaves without anesthesia. There's a lot of controversy, a lot of discussions now about the black race coefficient for the estimated GFR in estimating renal failure. In the interest of time, I'm not going to spend a lot of time on this, but these are things you can look up. So to kind of summarize, race does matter, because in this society, in this country, newborns are assigned the race of their parents at the time of birth. And if one parent is white and the other is of a different racial group, then that child is assigned the race of the non-white parent. So clearly, race is a very powerful social currency that is resistant to all sorts of changes. So, and whether you believe in it or not, it's there. So why is it important to go into all these history? Well, history is not just a bridge to our past, but it helps to illuminate the present. We need to learn from the past, because the past helps to shape the present. And it's important to understand that good intentions are not enough. This was a paper that was published in 2020, essentially looking at the log-adjusted mortality rate since the 1900 in this country, comparing black and white patients. And as you can see from the panel on the left, panel 8 here, those mortality rates have not crossed. It's like parallel lines that have never crossed since the 1900. Black mortality rates has been consistently higher than white mortality rate. Detail for the life expectancy. Black rates are lower than for white persons in the United States. So let's spend the next 5 minutes or so trying to come up with some solutions. How do we deal with this? The first thing to say is that, of course, as you can see, I don't have all the answers. And as a matter of fact, it will be unfair to expect that minorities will have all of the answers. We must all get involved. The same way that we cannot expect that women will fix all these sex abuse problems or the gender abuse problems, everybody must get involved. So what are 3 things that we all can start doing from today? Well, the first thing is to acknowledge that the problem exists. In other words, admit that health disparity is a crisis in this country. But good intentions are not enough. Just acknowledging is not enough. We need to take action. And one of the actions that we can take as you're listening to me is educate yourself. Just get educated. Learn about these things. Go into history, so that the more you know, the more you don't know, and the more you want to find out more about this subject. And finally, to say that we should all be health disparity researchers. We shouldn't just leave it to black and brown people alone. And that brings me on to the question of unforeseen or unexpected allies. What do I mean by this? These are people, or these are individuals that have no skin in the game, with all the pun that contains. These are just a few examples of unexpected allies and their role in history. If Abraham Lincoln wasn't interested in the Emancipation Proclamation, that would not have happened. If JFK hadn't been interested in the Civil Rights Movement, that would have been delayed. If John McCain hadn't cast that singular vote on the floor of the Senate, the Affordable Care Act would have died. So that's the role of unexpected allies. Even in the Bible, the role of Paul, who was formerly called Saul, who eventually became one of the most effective Christian evangelists in propagating Christianity. So that is the role of unexpected allies, and that is why I think minorities alone cannot fix this problem. It has to be an all-American problem. So I'm going to end with these timeless words from Martin Luther King Jr. And he says, "We are now faced with the fact that tomorrow is today. We are confronted with the fierce urgency of now. In this unfolding conundrum of life and history, there's such a thing as being too late. Procrastination is still the thief of time. We must move past indecision." Essentially saying that we all need to get involved. And I will end by challenging us that if this talk moves you, do something about it. Get involved in the health disparity investigation and trying to come up with a solution. I want to thank you very much for listening to me. And for those who are interested, these are 2 phenomenal books that I will encourage you to read. And just to thank my collaborators, particularly thanking the American College of Surgeons for making the NISCRIPT database available to us, and for my research collaborators, and to all the disparity investigators out there, I say keep up the good work. Thank you very much for listening to me, and I will be very happy to entertain questions. I hope that we'll be able to have a spirited discussion about this topic. Thank you.
Hello, everyone. My name is Dr. Travis Reeswin. I use he, him, his pronouns, and I'm here to talk to you today about perioperative gender-affirming care for transgender and gender diverse youth. I have no financial relationships to disclose. I'd like to start off by telling you a bit of the terms and definitions that I'll use throughout the lecture today, but also these terms that'll help you as you interact with these patients in the perioperative setting at your own institution. Gender identity is the internal perception of who you are as a person and your true gender on the inside. Internal is I for identity. You can contrast that with gender expression. So this is the external, so E for external and expression. This is how you present yourself to the world as your gender. This can be something as simple as the clothes you wear, your haircut, even how you choose your different name, etc. This is all variations of a gender expression. The biggest terms are cisgender and transgender. I want to make sure that we all understand what this truly means. Cisgender means that a person's sex assigned at birth corresponds or aligns with their gender identity. I am a cisgender man. So I was assigned male at birth and I identify as a man. I am a man. Therefore, I am cisgender. The opposite of that would be transgender. These patients their current gender identity does not align with their sex assigned at birth. So somebody that was assigned female at birth but is a man would be transgender. Now we can be more specific using the terms transmasculine or transfeminine. This acknowledges that transgender people don't have to be neatly in the binary of male or female. So somebody that is transmasculine is somebody that was assigned female at birth but identifies more on the masculine side than the feminine side. And the opposite would be transfeminine, somebody who is assigned male at birth doesn't identify as a woman, fully female, but they are more on the feminine side. A few other gender diversity terms that I'd like you to know would be agender and bigender. So agender meaning the lack of any gender. These people do not identify with any gender. And bigender are some folks that identify truly down the middle. So 50% female, 50% male. And gender fluid would be a subset of people whose gender expression and gender identity, how they view themselves and how they express themselves, can be a little fluid and change over time. And non-binary versus non-conforming would be people that do not identify strictly in the binary of male and female. They are somewhere in between, both with their gender identity and how they express themselves. A lot of these patients experience gender dysphoria. There are several types of dysphoria, being social, body, and mind. Social dysphoria is feeling uncomfortable presenting who you are to the world out of fear of discrimination, harassment, etc. Your body dysphoria is one that we hear a lot about, especially in the operative setting, because gender-affirming surgeries would be top and bottom surgery, etc. That would be to treat body dysphoria. And then the mind dysphoria is really when you're discomfort with your emotions and how you're feeling and how you're dealing with your own gender identity. In 2020, the Trevor Project surveyed close to 40,000 LGBTQ youth in the United States and found that over a year period, 50% had seriously considered suicide, 20% had attempted it, and 60% had engaged in self-harm. Now, LGBTQ is a large acronym and includes both sexualities, the L, G, and B, and Q, as well as a gender identity, which is transgender. And there is a very big difference in suicidality risk between those groups. You can see in the bottom left there, cisgender folks that are still lesbian, gay, or bisexual had 34% considered suicide and 11% have attempted, versus transgender, 52% had considered it and 21% had attempted. This is a big difference for people that are still in the LGBTQ community. And this also plays out because we see an increased risk of substance use, mental health disorders, rape and assault, harassment, bullying, etc., is all experienced by our trans and gender diverse youth. In 2015, the US Transgender Survey revealed that 33% of trans patients reported at least one negative experience within the healthcare setting. And these negative experiences led to 23% of trans Americans not pursuing medical help or seeing a doctor when they knew that they needed to. More specifically, transgender Californians, which is the state with the largest transgender population in our country, 35% of trans Californians had to teach their doctor or healthcare provider about being trans in order for them to receive the appropriate care. Now, that can be viewed as a burden, a minority tax, if you will, having a certain patient population explaining who they are to you, et cetera, over and over again can be very harmful. And 11% of trans Californians actually had care refused because they were trans. All of this discrimination and transphobia in healthcare has really led trans patients to have an underlying distrust of the medical field, and which really translates into increased perioperative anxiety. So how can we as anesthesiologists provide patient-centered care to help provide the best care possible for this unique patient population? We do that via gender-affirming perioperative care. We do that with 4 tenets of gender-affirming perioperative care, which is affirming communication, preoperative testing, have they had any gender-affirming care before, hormones, surgery, et cetera, or if they're taking medications, does that interact or change anything that I need to do as an anesthesiologist? I want to briefly go over these tenets. Affirming communication truly does mean using the correct name and pronouns for your patients. Often when trans or gender diverse youth and adolescents socially transition, they choose a different name and they choose to use different pronouns. So anytime I interact with these patients, I enter that interaction by saying, "Hi, I'm Dr. Travis. I use he, him, his pronouns. What's your name and which pronouns do you use?" There, very simple. And what that does is it says, I am an affirming and knowledgeable provider, and I'm here for you, and you can trust me, basically. Now, some of our gender non-binary patients use gender neutral pronouns, the most often of which is they, them, theirs. I hear often from medical professionals that using the singular they is extremely difficult for them, and they don't know how to approach it, etc. My answer to that is practice. I try to eliminate he, him, she, her out of my regular vocabulary when talking about people I don't know or referencing somebody in public, etc. So you can say things like, they are in the waiting room, the doctor is ready to see them. Anytime you see or hear the phrase his or her, you can easily replace that with they, them, their, etc. So each student should sit at his or her desk. Can be each student should sit at their desk. We use the singular they even in formal writing, especially in evaluations for medical trainees. I've worked with Dr. So-and-so in the operating room the past 3 months, and they have done a fantastic job. So we use it more frequently than people understand, and it's just getting over that mental hurdle. I guarantee you that people will mess up. I still occasionally mess up, and that is okay. What we should try to avoid and try our very best is to avoid misgendering or dead naming. These might be new terms. Misgendering is where you do use the incorrect pronouns to their face or when discussing them with other providers. And dead naming is where you use their old or their legal name, especially if they socially transitioned and they use a new name now. So try your very best to avoid that. But if you do make a mistake, please just apologize and move on. I say, thank you very much for correcting me. I apologize. I'll do better, and move on. Don't take the time to profusely apologize. Don't make this about you. Don't say, oh, this is so hard for me, etc. It's not about us. It's about providing gender affirming care for these patients. So easily, simple apology and move on. Another tenet of gender affirming care would be preoperative testing, especially common lab values. So if our patients have had hormone therapy, whether that's estrogen, spironolactone, or testosterone, this might start to alter our typical pre-op anesthesia lab values, specifically our hematocrit, hemoglobin, and creatinine. For our trans women patients that are on estrogen and spironolactone, we frequently will see a decrease in hematocrit, hemoglobin, and the creatinine, with a possible increase in your potassium due to the spironolactone. The opposite of that would be for our trans men who are taking testosterone therapy. We will see an increase in muscle mass, therefore leading to increase in creatinine and also erythropoiesis, so we get a higher hemoglobin and hematocrit count. Preoperative pregnancy testing is a really big opportunity to provide gender-affirming care for these patients. And I want to stress to you the basic biology of pregnancy when you're interacting with these patients. Regardless who these patients are, they must have a hormonally functional uterus and ovaries. They have to have and participate in receptive vaginal sex with a sperm-producing partner. I know that sounds somewhat self-explanatory, but often many of those aspects are not met with our trans or gender diverse patients. When you're asking these questions, I would encourage you and your perioperative staff to employ gender-neutral language when you're interviewing, so you don't have to ask, are your partners men or women or both or whatever? Because a trans woman could be a sperm-producing partner. So using gender-neutral language is really important here to gather the correct information. So who do we test? Who needs a preoperative pregnancy test? This is very important because we have to really consider pregnancy testing for any gender variant patient that we're seeing, whether they're trans or gender diverse in any manner. If they were assigned female at birth and have not undergone any gender affirming internal surgeries, such as a hysterectomy, oophorectomy, then we need to ask them these appropriate questions. Do you have receptive vaginal sex, and is your partner sperm producing? It can often be difficult within a system, especially in a electronic medical record, to do this. So for our trans men, if we allow their gender marker to change to male, it might be very difficult to order a pregnancy test for a 16-year-old man, for instance. I do want to draw attention to that preoperative pregnancy testing, especially for our trans men, can be very dysphoria-inducing. It's a very woman act, if you want to think of it that way, to quote, pee on a stick or provide urine for pregnancy tests. So if it is dysphoria-inducing, keep in mind that patients can refuse. That depends on each state and each country's laws. But it is possible to refuse as long as you have informed consent discussion. But if it's just the act of providing urine that causes the dysphoria, then I encourage you to allow your patients to provide a blood serum test instead. And most notably, we see this often is for trans guys, they say, no, there's no way I can be pregnant because I take testosterone. Well, that's not an accurate statement. Testosterone is not an adequate form of birth control for our trans male patients. Other questions we need to ask are about gender-affirming treatment. Have they been chest binding? Do they wear this tight garment to compress their chest tissue to allow for a more masculine physique? Is that something that I absolutely need them to remove before we go into surgery? Or can I let them leave that on so we can avoid any other dysphoria or anxiety in the immediate preoperative setting? And then truly, we need to know if they've had any surgeries before that would alter our anesthetic plan. Specifically, a vocal feminization surgeries called a Windler or an anterior glottoplasty, where we or otolaryngologists can denude the anterior 1/3 of your vocal cords, sew them together and form a scar, which shortens the vocal cords and increases the pitch. As you can imagine by these photos, you can see how that will change the airway anatomy and really impact how we manage that airway. But gender-affirming surgery can be several things. It can be something from hair removal all the way to building a neo-vagina or a neo-penis, and it spans the gamut in between. So these patients, though, can come to us for anything, even an appendectomy. So keep your mind open that any of your patients might be trans or gender diverse. Medication considerations, there's no drug-drug interactions that we're aware of yet, and there's insufficient evidence to hold your pre-op or perioperative estrogen or testosterone or spironolactone at this point. Most importantly, for Sugamidex, for our trans women taking estrogen, it is okay to use Sugamidex. These are trans women. They were assigned male at birth, and it is impossible to be pregnant. However, if your patient is a trans man taking birth control, you must counsel them like you do cisgender women, because Sugamidex will alter their birth control. I want to leave you with this. Having a positive experience within the medical system can be deeply healing for these patients. And I hope now you have a little bit more knowledge to help you provide that positive experience. Thank you.
Okay, so as people are coming in, first of all, I want to say thank you to Dr. Nafiu and Dr. Rees Nguyen for their presentations. I also want to invite people to ask questions in the chat, or if you want, you can unmute yourself. I think our group is small, so we will be able to do this. Thank you so much. Thank you for attending. I'm looking at the chat. I can start with one question if nobody else, while people are putting their questions in the chat. So this question is for Dr. Nafiu. I was interested if you could tell us a little bit on how we can change our systems to really acknowledge that issue that you so well explained about institutional racism or systematic racism.
Thank you, Natalia. I hope you can hear me. I believe strongly that charity begins at home is sort of one of the ways to think about this, and by that I mean just educating people at all levels, not just when we're talking about residents or fellows. By the time you become a physician, to me, I think it's probably a little bit too late. But starting from way before, there's all this controversy about, should we be exposing children to this sort of education? But I believe that knowledge is power, because it is the children of today that are going to become the healthcare providers of tomorrow, that are going to become the physicians and doctors. They're going to become doctors and nurses and pharmacists, hospital workers, and all those things. So really, starting at every level, whether it's high school, whether it's in college, do you know that it's possible to go through the educational system in this country without learning about systemic racism, without learning about the history of this country? And to me, that is a travesty. We need to be bold enough to face our past, so that we can better address many of these issues.
Thank you. And I was going to ask a similar question to Dr. Rees Nguyen. If you can tell us a little bit about some of the efforts that you have been leading in terms of providing adequate care for transgender and gender diverse youth, specifically in the operative setting.
Absolutely. So we here at Stanford have started what we call our GRACE program, which stands for Gender Recognition and Affirmative Care Through Education. And that's really been focused on educating just the perioperative staff. And it started just as a nursing initiative because we had patients scheduled to undergo a vaginoplasty, and everybody in the perioperative setting realized we don't know how to care for a patient in the postoperative setting that was going to have a vaginoplasty. So that sparked the need to fill this void. So we started talking about just the basics of gender identity, how that's different from sexuality, and what these patients go through on a regular basis outside the hospital, and then how that discrimination and anxiety translates to their perioperative setting. So we pulled in what we are now calling our nursing ambassadors from different areas, from pre-op, from our PACU area, but also from each of the recovery wards, so the patient care units of our hospital. And we really gave those ambassadors really in-depth training, both so they can fully understand the basics of gender identity and trans and non-binary folks and their experience, but also so that they could return back to their units and serve as ambassadors to help answer those day-to-day questions. We started initially with just those few. And so when any of our gender diverse patients would come through, we would make sure that they were interacting with somebody that had undergone this training. But now we've been able to train so many people that it's more ubiquitous that we have nearly everybody is trained in this kind of basics of interaction and affirmative care. And so what we've seen in our hospital specifically is a very pretty impressive decrease in kind of discrimination and complaints and, oh, these people misgendered me before I even, got to the pre-op setting. All this is what we were encountering, unfortunately. And now since the training, we've been able to significantly decrease that. So it starts with everybody, both surgeons, nurses, and now we've branched out into our admitting team staff at the front desk, our security staff, and even our laboratory staff that comes out to ask for their pre-op lab testing.
Great. Thank you so much for sharing with us. I am going to put you on the spot, Dr. Lubukola. I think it's appropriate for this particular audience. Can you tell us a little bit about the new health disparities section from the ANA? You are the head of the section, and I think it's worth telling people, because I think that is one of the systematic changes that I applaud from the journal.
Thank you, Natalia. I'm never ashamed or shy to put in a plug for the health disparity section that ANA has created, and I really wish that this session was not in the so-called graveyard session whereby everyone is tired. It's the end of the day, and so that we could have a much larger participating audience. But really, the the health disparities section that ANA established, I would say that it's, number one, it's a first in anesthesia, and knowing that ANA is one of our flagship journals, to me, it's really, really commendable. Creating a section dedicated to health disparity work. I believe that, we all know that ANA is the clinicians journal, the perioperative clinicians journal. And I believe that they've lived up to that, that level of being all inclusive and just all welcoming. And my hope is that that section is going to generate a lot of interest among healthcare providers. Just like I said, we should all be health disparity investigators, not just limiting it to people, brown and black people only, because at the end of the day, it is an American problem. It is a problem that involves all of us, and it's a problem that impacts health disparity is a problem that impacts all of us, either directly or indirectly through tax dollars. So yeah, send in your papers to the ANA health disparity section. So
Thank you so much. It's the end of our session, but I'm hopeful that other people will see the recording, so our message will get amplified. I really want to thank people who joined us for this stimulating discussion, and enjoy the rest of the meeting.
thank you, everyone.
Thank you.
Thank you.
Bye-bye.